Hi, good morning, good afternoon, good evening, everybody. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris in France. And it is my great pleasure to welcome you all to this new journal club by the International Academy for Clinical Hematology. I'm sure you're all now familiar with the journal clubs of the IACH. We have them every 15 days, a couple of journal clubs every month, except during holidays in the summer. And as usual, the Scientific Steering Committee of the IACH would propose a recent article to be discussed with one of the co-authors, usually first or senior author, but also with an expert in the field who is not a co-author. So I'm very grateful to the unrestricted educational grant we receive for these educational activities. And for today's journal club, the choice was about this very recent article published in Nature Medicine and entitled Gut Microbiome Correlates of Response and Toxicity Following Anti-CD19 CAR T Cell Therapy by Dr. Melody Smith and colleagues. This is the abstract of the article, and actually this is a fascinating story because more and more we have, I think, accumulating evidence about the role of the microbiota, especially dysbiosis, so alterations of the microbiota in cancer in general, and this has been shown with conventional chemotherapy a few years ago. It has been more recently shown in the field of solid tumors, the capacity of restoring the microbiota and reverting the dysbiosis to improve or to overcome resistance to immune checkpoint inhibitors. But also, of course, there is a huge body of evidence showing the correlation, for instance, with the microbiota alterations and the outcome after allogeneic stem cell transplantation. And this has been ongoing now, and data are quite robust in this field since almost 10 years. Here we have really a novel work, a novel field, very innovative, where the authors thought to look into the impact of the microbiota status on the outcome of patient receiving CAR T cells. And the focus was on the anti-CD19 CAR T cells, which we know are approved and widely used both in non-Hodgkin lymphoma and acute lymphoblastic leukemia. And they have shown a very nice correlation. And of course, we will discuss about the issue of causality, that actually prior exposure to larger spectrum or to antibiotics, large spectrum antibiotics, is going to negatively impact the response to these CAR T cells, but also it will have an impact on the incidence of some of the specific toxicities with CAR T cells, namely CRS, cytokine release syndrome, and neurotoxicity. And this is one figure from a couple of panels I copy and pasted from the beautiful paper showing actually the shape of the curves. I don't think we need to look into the p-values, but clearly when you look into the shape of the curves between those patients who are exposed versus not exposed, whether non-Hodgkin lymphoma or whether acute lymphoblastic leukemia, and this is about exposure, of course, to these wide spectrum antibiotics in the few weeks before receiving the CAR T cells, you can see clearly a significant impact. And the authors did a very nice analysis. For instance, this univariable and multivariable analysis of looking into the different prognostic factors. And to make a long story short, definitely the exposure to these wide spectrum antibiotics and its correlate of dysbiosis, in my opinion, has really a very important hazard ratio when it comes to the outcome of these patients. And they were talking about overall survival, of course. And here you can see the methodology that was used for confirmation, because there were two cohorts, one retrospective large cohort, 200 plus patients. But I think the authors did a great job having a prospective cohort of 48 patients with a prospective fecal material collection for analysis, and they could nicely show, for instance, the imbalance, the lower fecal diversity in the patient. This is the baseline. These are the patients here in blue, and compared to healthy volunteers who are supposed to have a healthy, or let's say normal, microbiota. So here I will stop my introduction, and would like to have a warm welcome to Dr. Melody Smith from Stanford, who is the first author of this beautiful Nature Medicine paper, and who kindly accepted to be our panelist today. And we will have Dr. Florent Malard from the Sorbonne University, who is also an expert in this field and presented some nice work recently at ASH at EBMT about the role of microbiota in the field of GVHD. So first of all, Melody, congratulations for this paper, and thank you for dedicating some time for us. Florent, thank you for dedicating time. And as usual, my first question during the Journal Club goes actually to the panelist who wasn't a co-author. And it's relatively simple. What was your reaction, Florent, to this paper when you saw it for the first time after publication? I know you follow this field very closely. Was it, wow, this is fantastic, and you were very excited, or then you said, oh, well, please tell us your feeling, your general feeling.
Yeah, so thank you, Mohammad, for the presentation. Thank you, Melody, also, and congratulations for this amazing paper. So since I congratulate Melody, this is that I feel this paper very exciting and very interesting, and we were really waiting for the data, because we have seen some oral presentation on the microbiota on CAR by Melody at previous Congress, and we're really waiting to have some more data and to have some more insight regarding the link between microbiota and outcome after CAR T cells. And as soon as the paper were published, I read it, and I think, yes, this confirmed what I was thinking, that there is an impact of microbiota on response to CAR T cell on patients' outcome after CAR T cells. And it was also very interesting to have the data on toxicity. There is no link with the cytokine release syndrome, but there is a link with neurotoxicity. I was more surprised by this data, and we really would like to have now some more mechanistic data regarding this link between the neurotoxicity and the microbiota. But regarding the link between microbiota and response on patients' outcome, I am totally convinced by the data.
Fantastic. Thank you, Florent. And I forgot to mention, of course, to all our colleagues attending that please do not hesitate to send your questions either using the discussion icon or the Q&A. And of course, I'll share them with Florent and with Melody. So now, Melody, my next question is to you, and would love to hear from you the rationale behind, doing this work and this analysis. Why did you choose to do this? What was the background behind it? Because maybe you could have, I don't know, tested something else, what's the correlation between the color of your eyes and, the outcome of CAR T cells in a given patient? Why did you focus on the microbiota?
So thank you, first of all, Dr. Modi and Dr. Mallard, for your comments and also for inviting me to discuss this article, which was the result of a collaboration over several years between investigators at Memorial Sloan Kettering and the University of Pennsylvania. So you're asking why I chose to investigate this correlation. So when I conducted this work, I was in my postdoctoral mentor, Marcel Vandenbrink's lab, and in that lab, one of the areas of focus for our research is the understanding really the associations and really delving into how the intestinal microbiome impacts outcomes following allogeneic hematopoietic cell transplantation, with a focus on impacts of graft versus host disease, relapse, infection, et cetera, using both animal models as well as patient data. And when I was in the lab, I was really focused on investigating CAR T. I really had initially nothing to do with the field of microbiome research. I would hear these discussions and conversations in the lab meetings, et cetera, but it was not a focus of my research. I was really focused, and also one of my ongoing areas of research interest is understanding ways to engineer donor CAR T cells. But I think it was around 2018, in addition to knowing the literature in terms of the microbiome and intestinal and allo-HCT outcomes, there were several papers around that time that came out about the microbiome and immune checkpoint blockade. And that mounting data in terms of the importance of the microbiome for immune checkpoint blockade and thinking about its impact on immunotherapies in the setting of cancer really is what pushed me to want to investigate how the microbiome may impact CAR T cells. And from there, really the research question was sort of spawned and developed from there further. Yeah.
Very clear, thank you. And actually, you nicely alluded to the fact that we have indeed, we've seen in the last 10 years or so, an accumulating body of evidence about the interactions between the microbiota and different interventions in cancer. So maybe Florent, can you, because of course at the IACH, our audience is very, I would say, heterogeneous, because we have leukemia doctors, we have transplanters, we have general hematologists, local and community doctors, other healthcare professionals, nurses, etc. So maybe Florent, before digging a little bit deeper into the content of the study, and the paper is really fantastic, can you remind the audience about what do we know today about the microbiota interactions and correlations and dysbiosis in different disease settings and treatment settings in hematology and cancer in general?
So for the last 10 years, there was a lot of data published that link microbiota with patients' outcome, mainly in the setting of allogeneic stem cell transplantation. It was mainly on the pioneering route from the Marcel Vandenbroek's lab and also Eric Palmer lab at the Memorial Sloan Kettering. And there was the first study that linked microbiota diversity at engraftment with patients' outcome, and in particular overall survival after allogeneic stem cell transplantations. This single study was recently confirmed in a New England Journal of Medicine paper published 2 years ago now. It was a multi-center study that included patients not only treated at the Memorial Sloan Kettering in the US, but also a second center in the US, patients treated in Japan and also in Germany. So in this they confirmed that gut microbiota diversity at engraftment were associated with overall survival, with patients with lower diversity having a lower overall survival. And the effect was mainly related to a higher non-relapse mortality in those patients. They also highlight an impact of gut microbiota diversity not only at engraftment, but also before allogenic stem cell transplantation. It was already important. When we look more in detail, they seem that there is an effect on the risk of graft-versus-host disease with this loss of diversity, and in particular when there is more some detrimental bacteria such as the Enterococcus, Enterobacteriaceae, that is associated with an increased risk of acute graft-versus-host disease mortality. In part, there is also a link with infectious complication. This is expected, and there is a final article that links gut microbiota diversity with the risk of relapse after allogenic stem cell transplantations. So it was some very important data because there is a link between patients' outcome, VHD, infectious complication, but also the risk of relapse. And in fact, when we move in other setting and when we are looking, for example, to the setting of autologous stem cell transplantations, they analyze the impact also of gut microbiota diversity after autologous stem cell transplantations and neutrophil recovery, and they find that it was associated not only with overall survival, but also with progression-free survival, suggesting that microbiota also have an effect on the risk of relapse after autologous stem cell transplantations in the setting of patients treated for lymphoma or myeloma. And this leads me to the last data we have also in the lymphoma field and in the myeloma field, in particular in the myeloma field. There is also some data that link this microbiota with the risk of with the outcome after autologous stem cell transplantation and with MRD positivity for myeloma patients. So it suggests that besides immunological complications, gut microbiota diversity is also associated to the response to chemotherapy in the field of intensive chemotherapy. And we have some similar data if we look at the field of solid cancers. We have the data with the cyclophosphamide. This is from Laurent Zipogel groups in next to Paris that find a link between the effect of cyclophosphamide in solid tumors and the microbiota, and also with immune checkpoint inhibitors in melanoma patients also with lung cancers and so on. There is a direct link between the gut microbiota diversity and the response to immune checkpoint inhibitors, and it was recently published in 2 papers in Science last year that if you perform some fecal microbiota transplantations in some patients that were not responding to these immune checkpoint inhibitors, you take some feces from some patients that respond to the immune checkpoint inhibitors, you put them in the non-responding patients, and after the FMT transplant, the patient is going to respond to the immune checkpoint inhibitors. So there is a direct link between these gut microbiota compositions and the response to the immune checkpoint inhibitor. And this is very exciting because maybe, and we'll discuss this later during this meeting, I hope we can think about this kind of treatment we can perform in our patients with hematological disease, in allogenic stem cell transplantations, autologous transplantations, CAR T cell, we'll discuss this today, and maybe some other treatments.
Wonderful summary. Thank you, Florent. And indeed, we'll discuss the therapeutic implications. Now, my question to you, and we have already a couple of questions about this melody, is that, so what you could show is that if the patient has received large spectrum antibiotics 4 weeks before, within this window of 4 weeks before CAR T cell, they are not going to do well after CAR T cell. But also I'm a believer, I may be the devil advocate and would say, well, if they needed these antibiotics before, probably these patients are in poorer shape and may have other, I would say, risk factors or characteristic for not responding. So what would be your answer to this?
Yeah, so I think, definitely Florent laid the really clear groundwork in terms of the literature in the field of cancer immunotherapy and the microbiome. So I also want to, in response to your question, add that there have been multiple studies in the field of immune checkpoint blockade that have found that exposure to antibiotics before or after checkpoint blockade are associated with worse outcomes. And so knowing that many medications, but specifically antibiotics, can cause perturbances to the intestinal microbiome, inducing dysbiosis, I wanted to investigate how these antibiotics may impact outcomes, as you showed briefly in your slides. And so we did find that the exposure to antibiotics resulted in decreased PFS and OS in both ALL and non-Hodgkin's lymphoma patients. And so that was my initial question. Is this really a confounder for patients who were sicker that received antibiotics and then thereby did worse? So we're really just showing that these were sicker patients. I think two responses to that. One, you already showed the multivariable analysis that shows that when we accounted for various patient and disease-related factors that had been associated with CAR T-cell outcomes, two of which have been published, that a higher pre-lymphodepletion LDH is associated with worse overall survival, as well as a worse ECOG performance status being associated with worse overall survival. Our multivariable analysis confirmed those two findings and also showed that exposure to PIM antibiotics in the 4 weeks prior to CAR T-cell infusion was also an independent variable. That's one thing that kind of suggests that. But the other thing that I think is even more convincing is that between the two centers, MSK and Penn, there was a preference for which broad spectrum antibiotic patients were given in the setting of neutropenic fever, with Piptazo being more commonly, or Zosyn as it's referred to as well, being more commonly administered at MSK, and Cefepime more commonly administered at Penn. Both of these are broad spectrum antibiotics, but Cefepime targets anaerobes or obligate anaerobes to a lesser degree. And we saw that in patients exposed to the Piptazo drug or that combination had worse overall survival, but those exposed to Cefepime did not have a reduction in overall survival. So that to me is suggestive. It's not just exposure to antibiotics, but it's the bacteria that those antibiotics target, which is associated with that outcome. So I think that helped to clarify the potential confounder of antibiotic exposure.
No, definitely. I think this is quite convincing. And that brings me actually to the next question. And again, I think our audience is contributing actively to this, is about the implications for antibiotic stewardship. And I think we in the hematology field have been always educated to be very generous, just to be on the safe side, don't take any risk, just give the most powerful antibiotics, which maybe today is not proving to be the right attitude. So Florent, based on what we just heard from Melody, based on the content of the paper, what are your thoughts about antibiotics management and choices one should adopt in these patients? And you see most of these patients who receive CAR T-cell in your department. And is this going to push you to modify your attitude? Because I think we had this discussion also in the field of transplant and acute leukemia, saying, oh, do we need to give imipenem to everybody, or meropenem or whatever?
Yeah, this is very interesting to see this difference between the Piptazo and the Cefepime, as highlighted by Melody. And this suggests that maybe we should use Cefepime when we have a patient that is going to receive some CAR T-cell within the next month. You have some fever, we need to give some antibiotics. It is mandatory. We have to give the antibiotics because otherwise the patients may die because of the infectious complications. So we don't have the choice. We need to give the antibiotics, but we have the choice for the antibiotics most of the times, and we can use Cefepime for those patients most of the case. In some patients, because we already know that you have some infections with a particular kind of bacteria, and in these particular situations, it may be mandatory to use Piptazo or Penem, but otherwise, I really think that we should change our practice and have some Cefepime as the standard first-line treatment for those patients.
So your recommendation would be to be a little bit more liberal and because we've been always very conservative. Melody, do you share the same feeling now that you have seen these results?
Definitely, I share the same feeling. I would say, though, that I think that this data warrants a randomized study to assess that. Similar to what has been done, there's an ongoing study at MSK in the allotransplant setting, giving some of the data that we saw with anaerobe targeting antibiotics versus, cefepime. And so I do think that it would be one of the next steps, maybe I'm jumping the gun in terms of sort of some of the thoughts for future directions from this data, but I think it would be beneficial to have a randomized study assessing just this question. Antibiotic stewardship and randomizing patients to either cefepime or piptazo, if possible, in the peri-transplant CAR T cell window.
Well, fantastic. Let's move 1 minute to the complications. And I read this paper very carefully. And what I noticed, for instance, when it comes to neurotoxicities or ICANS, actually you found the impact of dysbiosis in the non-Hodgkin lymphoma patient, but not in the acute lymphoblastic leukemia patient, which for me is a bit weird, but there's probably a good explanation for this. What are your thoughts, Melody?
So we really drilled down on some of the subset analyses of our non-Hodgkin's lymphoma patients for a variety of reasons as compared to the patients with ALL. We found that we had a more homogeneous contribution of the various CAR receptors that they received from the perspective of the co-stimulatory domains when we looked at the non-Hodgkin's lymphoma as opposed to ALL patients. And speaking specifically to the neurotoxicity that we found to be increased in patients with non-Hodgkin's lymphoma who were exposed to one of the PIM antibiotics, as compared to patients with ALL, we didn't see that. I think it could be related to maybe some underlying disease biology, but to be fair, we did not yet explore that. So we assessed that it could be some of the differences in the disease and lymphoma. It's more in your peripheral lymph nodes and in the organs as opposed to disease circulating in the blood. So that could be impacting our ability to detect some of these differences with ICANS, more so in non-Hodgkin's lymphoma as opposed to ALL. But I do think it requires further investigation.
Excellent, thank you. We have a question here. Maybe I'll direct it to you, Florent, because the paper here was focused on anti-CD19 CAR T cells, but we know that since last year we have also CAR T cells in multiple myeloma, but the target is different. So this is usually BCMA, the B cell maturation antigen. Do you think that if we perform the same study in patient with myeloma receiving CAR T cells, can you speculate whether we would find the same results? And I'll ask the same question to you, Melody, so you have a couple of minutes to think about it.
Yeah, this is a very good question. And of course, it will be only about speculations because we don't have the data. And I don't have any hidden data I can share with you. But my speculation will be that I hope we'll have a similar finding because we have this data in the patients with myeloma that receive autologous transplantations that link microbiota diversity with outcome and in particular progression-free survival that involve relapse of myeloma. This is these links that first suggest a link between the microbiota compositions and the risk of relapse. And we know that microbiota is impacted by the use of antibiotics. There is also another data. It was an article published several years ago in Nature Communications that look more in details into the pathophysiology of myeloma, and they find that microbiota on some bacteria could intervene into the promotions of myeloma. In a mirror model, they show that there is transformations between a pre-myeloma to a myeloma in this mice based on the presence of absence of some kind of bacteria. So there is a very strong data that link microbiota risk of relapse and a history of myeloma. And based on this, I really suspect that in myeloma patient that will receive CAR T cell will also find an impact of the antibiotics on the microbiome.
Melody, are you on the same line?
I'm definitely on the same line. I think the other thing that I would add is that these are T cells, right? They're targeting different tumor targets, but they're T cells. And I would hypothesize, sort of along similar lines as Florent, that not only the diversity changes, but even some of the taxa abundances that are associated with outcomes, such as efficacy and maybe even toxicity, may overlap because we're highlighting some differences in the T cells. And I think that even when we look at our data and some of the bacterial taxa that we identified to be associated with improved outcomes at day 100, there's overlap between many of the taxa and what's been identified in the immune checkpoint blockade literature. So I guess in some, even though the target is different, BCMA versus CD19, I think that there will be some overlap in terms of the findings.
Excellent. Thank you very much. And that's great because you give me the opportunity, because you mentioned the bacteria taxa you found. And indeed, what you found, you identified species within the class Clostridia, for instance, Bacteroides. And one of your speculations is about the role of the Butycore and the short chain fatty acid Butyrate, which are playing a role there. So maybe I'll ask Florent, can you please clarify, Florent, because I think you had the same hypothesis in GVHD, for instance, when you treat them with fecal microbiota transplantation, about the importance of this issue of Butycore and the short chain fatty acid Butyrate. And then I'll ask the question to Melody, how does it work in the CAR T cell, in the patients who are receiving CAR T cells?
I am on mute, sorry. So thank you, Mohammed. So in fact, what we find in the field of allogeneic stem cell transplantation, in particular of graft versus host disease, that there is a kind of set of bacteria, mainly that belong to the Clostridiales, that are going to produce a butyrate, so a kind of short chain fatty acid, and this butyrate will be associated with some kind of immunoregulation, that it will induce some regulatory T cells, and it is one of the hypotheses that this is what mediates some of the beneficial effect of the microbiota, in particular of fecal microbiota transplantation. When you perform an FMT, for example, to treat graft versus host disease, you will give some butyrate producing bacteria that will produce butyrate that will be metabolized, and that will induce some Tregs, and that will lead to the response of graft versus host disease. So this is a very important set of bacteria with this kind of beneficial effects, and we can suppose that maybe it have some similar effects on the CAR T cell, but I will let Melody speak.
So these are the good bugs. Okay, Melody.
Yes. So I agree. These bugs, these butyrate producers have been reported to be beneficial. They're important for maintenance and differentiation of T cells into T regulatory cells. Interestingly, we find that these butyrate producers were more abundant in those patients who had a day 100 complete response. So I'm talking about Ruminococcus, Faecalibacterium presnudsi, which has also been reported in the checkpoint blockade literature to be associated with improved response following anti-PD-1 therapy, that this is more abundant in those patients who had a day 100 complete response, and also more abundant in those patients who did not experience toxicity. And this was pulled to combine both CRS and ICANS, so the two most common types of CAR-mediated toxicity. So I think that left me really wanting to understand a bit more about butyrate regulation. We know that depending upon the level of butyrate, it can be more, differentiation towards Treg versus less. So the butyrate literature, I think, is really fascinating. And I think that this is something that we'll need to explore in mechanistic mouse models, not only those bugs, but also other metabolites. There was a really nice paper that I'll allude to that it was published in Science, I believe, by Kathy McCoy's lab in 2021, and it looked at inosine, and it was looking at Bifidobacterium longum and really highlighted abundance of that bacteria and its importance in patients in a more mechanistic model in mice who received anti-CTLA-4 based therapy, and identified that inosine was the metabolite that was produced, and found that that was really critical for the improvement in the checkpoint blockade. And so I guess I'm just alluding to that story to say that I think work like that needs to be done in the CAR T cell field to characterize not just the bacteria, but what metabolites are these bacteria producing that are then modulating CAR T cell response. Could be butyrate at varying concentrations, but it also could be other metabolites that we haven't yet honed in on.
Okay, wonderful. So here as this same line, we have a question from, I think, a patient who is attending this webinar. So okay. I say hello to all the patient and families, and we are very grateful to your contributions to the different studies and for helping to advance research. And of course, searching for a cure, because at the end of the day, it's about curing these patients with these terrible hematological malignancies. So the question is for you, Florent, is are there any specific diet recommendation that would favor butyrate production? Which I think is a good question, you know.
Yeah, this is a very good question. It's most of the time this is always difficult.
Then it'll allow me to choose my dinner tonight, you know.
Yeah, so for the patient it's always difficult, because for most of the patients it is most of the time very difficult for them to eat anything because of the chemotherapy side effects. So we're always happy when they eat something, even if this is not always a good food. But if we have to make some recommendations, of course we will have some more fiber that will induce this kind of butyrate producing bacteria. So if I have one recommendation, eat more fiber to improve your microbiota before you receive your CAR T cells. But of course, it will be very interesting to have some prospective study that analyze exactly what kind of food is eating the patients, to correlate this also with antibiotics, with the amount of food that is eaten, with the gut microbiota compositions, on assess what is the impact of the outcomes. So it will be interesting to have this data, but based on what we know from the literature, without the data, I can only recommend to eat on if we can eat some fiber.
So we have here a nice comment from Dr. Urvi Shah, who is telling us that this is being studied also in plasma cell disorders. Thank you, Urvi. So my understanding.
And I also, if I could just mention,
yes,
I can tell you that that was something that we were working to develop ways to collect that data in Marcel's group. And so I know that in his lab, there's also an ongoing effort to collect more detailed dietary data for CAR T cell patients, for just to be able to assess just that question, to understand the diets and how that modulates the bacteria, which we know it does. And I completely agree with Florent. In absence of the data, the literature would suggest high fiber diets would promote butyrogenic bacteria.
So what I understand is that it's definitely about avoiding tonight for me a cheeseburger and fries. Did I get it well?
For so many reasons.
Okay, good. Thank you very much. So more fibers, guys, even if you're not sick. Okay, we're almost reaching the end of this lovely journal club. I'm really enjoying it, and I'm learning a lot from both of you guys. So my next question to you, Melody, and same question to you, Florent, so you have time to think about it a couple of minutes, is what's next? Okay, you have observed this fantastic work, Nature Medicine. Now, the next step, in my opinion, is about trying to improve the outcome of these patients and maybe acting on the microbiota and correcting the dysbiosis. And of course, you think that I'm thinking about fecal microbiota transplantation, but you may disagree with me. So if you have to think about a clinical trial to perform in patients who are receiving CAR T cells, and you may wish to focus on lymphoma, myeloma, ALL, or mix them all together, what would be the ideal design for you, Melody?
So definitely think that clinical trials would be important to apply this knowledge. But before applying this knowledge, I think it's important to repeat in a larger study, in a larger multi-center study with more patients, similar to what Florent alluded to with the multi-center study, international study with the allogeneic transplant graft versus host disease and microbiome studies that were published in the New England Journal of Medicine about 2 years ago. I think it's important to, before acting on some of these findings in such a small cohort, to follow up on it. But I think that then after that, the next step would be to consider FMT. I think there would be three things that I would say is clinical studies. FMT, so basically assessing patients who either haven't responded to CAR T cells or checking their microbiota, finding a way that we could very rapidly sequence them and see, do they have, requisite abundances of bacterial taxa that we have identified to be beneficial, a consortia of bacteria that we've identified to be beneficial. If they don't, administering FMT. I think another important takeaway already from this data is to do a randomized study of antibiotic stewardship and evaluate that in the pre-CAR T cell setting, while also collecting fecal samples from the patients and understanding the abundances of the bacterial taxa and how they're impacted by exposure to cefepime versus piptazo, for example. And then the other aspect, which is not a clinical trial, but I think will help to inform a clinical trial, is mechanistic studies in animal models to understand specifically the bacterial taxa and the metabolites. And that's really where I'm focusing my effort in my lab, understanding the mechanism that's driving these impacts that we're seeing, so bring it beyond the level of association and to understand more causative implications of the microbiome for CAR T cell outcomes.
Fantastic. This is really great. Florent, so if I'm offering you a generous grant tonight, to design a trial for tomorrow morning, what would be your best trial?
So first of all, I totally agree with Melody. This is some very great data in the Nature Medicine paper, but we really need to have this kind of multi-center study from some patients across the world to really confirm the data, and that it will be very exciting to have this result from the animal models to have a better understanding of the mechanistic of actions. If you want to move to the clinical trial and to say, so we have this data, but we want to as soon as possible improve patients' outcome, I think what we should do, it seems that it's already the antibiotic that have an impact of the microbiota before we perform the CAR T cell. So I think we should think about a clinical trial when we perform an FMT before patient is going to receive the CAR T cell treatments to restore its microbiota diversity, to give some butyrate producing bacteria before we perform the FMT. So I will think about a clinical trial when we will perform an FMT before we start the conditioning regimen for the CAR T cells. And after we'll see if this is effective, and we can think about a randomized study with some patients receiving the FMT and some patients receiving nothing or kind of FMT placebo, if this is feasible, and assess what happened.
But let me challenge you 1 minute, 1 second, Florent and Melody, you may wish to react. Is that okay? I agree with you. You're going to intervene with FMT and correct the dysbiosis before CAR T cell infusion, and that's great. But we also know that these patients may get infected later on after CAR T cell, and they will receive antibiotics again. And then maybe you will go back to the baseline, and generate dysbiosis. So how are you going to handle this? I mean, in theory, is this about like sort of a maintenance therapy with FMT? In theory, you may need to have pills and things like this.
Yeah, this is a good question. In fact, we from the article, the data we have, this is very clear. This is the impact of the antibiotics before the CAR T cell. We don't have the data of what is the effect of the antibiotics after the CAR T cell infusions. Maybe there is an effect, but in fact, since the effect of the antibiotics before is stronger, we don't see the effect after. So we can expect that there is an effect after. I don't know if Melody has the opportunity to look at that, so what is the reason? So we need to go more in details on the effect of antibiotics after CAR T cells. And if there is an effect, in fact, of course, we need this kind of maintenance on maybe on the patient's neutrophil recover, we can perform a new FMT again, just to consolidate the effect of the first FMT. But we still need some more insight. But of course, it seems very interesting to have this kind of data.
No, I agree. I agree that the next question and something that we're actively evaluating is the antibiotic exposures after CAR T and the impact that those have on the CAR T cell outcomes. I think, however, and I think that's an important question to address, but if we glean some insights from the data that I think Florent and I both alluded to in terms of the administration of FMT to patients who received immune checkpoint blockade, were resistant, then responded after the FMT, that suggests that the FMT before the therapy would be a very critical one to improve the response, even if the patients are going to receive antibiotics after because of fever or various toxicity. So definitely the data needs to be published and identified in terms of post-antibiotic exposures, but I don't think that that would necessarily obviate the benefit of an FMT before.
Wonderful. I think that was a lovely conclusion. I think we can spend hours discussing this. Is really fascinating, and the microbiome modulation is really opening a new frontier, I would say, in cancer and hematology. It's 11:15 a.m. in California for you, Melody, 7:45 p.m. here in Paris, 6:45 p.m. in London. I'd like to thank you all for following this journal club by the IACH. Thanks to our loyal colleagues and audience, and thank you for your questions. Unfortunately, we're not able to take all the questions because of for the sake of time, but I'm sure you can reach out to our panelists by email. So for the time being, I do thank you all for your attention. We'll close this journal club. Thank you very much, Melody. Thank you very much, Florent, for sharing your time with us. And as usual, wherever you are, please stay safe and keep well. See you soon.
Thank you.
Thank you. Bye.
Bye.